I have a lot of pearls of wisdom to share with you this morning. We're going to talk about three main things. We're going to talk about the interim final rule, or what we're called IFC3, that was released at the end of August and published in the Federal Register in the beginning of September, as it relates specifically to some physician or clinician items. We'll go into a little bit more detail with the 2021 proposed rule, and then we'll finish up with some just general announcements about the upcoming CMS flu vaccine and what we're doing in terms of outreach. I gave Sharon the copy of my presentation yesterday morning, and then when I was going through it again yesterday afternoon, I said to myself, this is a lot. There's a lot of information in here. I took a few slides out because I figured that we get into conversations or discussions on some of the more pertinent points, we may take a little bit more time. So if you happen to have received the PowerPoint or a copy of my presentation ahead of time, and you were waiting with bated breath for me to discuss something, and I happened to skip that slide because I did take a few out, I'll give you my email address at the end of the presentation. You folks are not shy with getting in touch with me. We've been doing this for a number of years now, so please feel free to do so. So let us start with, well, actually, first let's start with the disclaimers, and this is the typical disclaimers that we always give before one of these presentations. It just basically states that anything that is discussed in this presentation, while it is taken directly from the rules and from the regulations, it does not supersede the actual regulations. So all Medicare policy is found in the actual pertinent rules and regulations. So we always give that disclaimer. So let's start with the interim final rule. And as you can see, it had a very lovely, lengthy official title when it was published in the Federal Register. We're just going to call it IFC3. And we call it IFC3 because in response to the public health emergency for the COVID-19 pandemic, we have issued now 3 interim final rules. And we discussed the first IFC back in April. We met on April 14th. And that was when we began to expand the use of telehealth services. That was done around March 31st. We had a subsequent rule that even further expanded telehealth and did other things too, but telehealth was really the big ticket item, as I call it, at the end of April. The IFC3 that was released on released on August 25th and then officially published in the Federal Register on September 2nd, really spoke to more of the institutional side of a house. So if you are at all familiar with what was in IFC3, you saw things such as new reporting requirements for hospitals, critical access hospitals, skilled nursing facilities, and labs. And what we were doing in this rule was basically moving voluntary reporting into mandatory reporting requirements. And there are things that CMS are implementing in order to make that mandatory. We also are implementing mandatory testing requirements for both staff and residents of nursing homes. So we're not going to get into too much detail since that is more on the institutional side, but I did want to bring, and Jennifer asked me to bring to your attention some of the, I guess, part B or the clinician part of the latest IFC. And the first one is a revision of our policy of obtaining a COVID-19 diagnostic test or a serology test, which is the antibody test. We had originally said in one of the previous interim final rules that Medicare beneficiaries could go and get a test without a physician or other practitioner's order, and they could get unlimited testing. What we are changing with IFC3 is that we're establishing that one COVID-19 diagnostic test and other related tests in order to rule out COVID-19, such as RSV or influenza, are deemed to be reasonable and necessary for Medicare payment purposes. So for the COVID-19 and other related diagnostic tests for which an order is required, we're also establishing a policy whereby the test can be covered if they're ordered by a pharmacist or other healthcare professional who is authorized to order diagnostic laboratory tests within the scope of state and other pertinent laws. So the limitations, so now we're saying you can get one test without an order, and then all subsequent tests would need an order in order for Medicare to pay for it. A limitation on tests will apply beginning on August 25th when the IFC was released, and any tests that were furnished prior to August 25th would not count in terms of the new limits. And CMS is revising the policy both due to the significant potential for fraud, waste, and abuse, as well as the public health and safety issues that would arise from beneficiaries being subjected to repeated testing without proper medical attention or oversight. And I always tell the story. I actually had 2 serology tests, one that was ordered from my physician, one that was not ordered from my physician. And my doctor told me, always make sure that you let me order it because you don't know what type of test you're getting. This was in the time when they weren't sure what the serology tests were. So CMS, that's just an anecdote. But again, the idea is not only to stave off the possibility of fraud, waste, and abuse, but also to make sure the beneficiaries are getting the proper guidance in getting those tests. We also reiterate in the proposed rule that we're going to be talking about that pharmacists may provide services incident to the professional services under the appropriate level of supervision of either the billing physician or the practitioner if the payment for the services is not made under the Medicare Part D benefit. And again, that is reiterated in the proposed rule, which we'll talk about. In terms of MIPS, and we'll talk about the changes to MIPS for 2021, but specifically some minor revisions or changes to MIPS for 2020 as it relates to COVID-19. We have recently, in previous rules, expanded MIPS telehealth services and eliminated frequency limitations and other requirements to facilitate increased use of telehealth in order to minimize exposure risk to beneficiaries. What we're doing in this IFC, we are now going to be including the codes for communication-based or communication technology-based services. And this is specific for those groups that are using either the web interface, which is going to be going away next year, by the way, but the web interface can still be used by groups of more than 25 for reporting quality measures. And also for those groups that are opting to use the beneficiary satisfaction survey called CAPS. There is a methodology by which beneficiaries are attributed to certain physicians or certain physician groups based on a plurality of the services that they received in a given time period. And what we're doing in this rule is because the use of telehealth services basically dramatically increased from March, we're making sure that those telehealth services that otherwise would not have been counted are now counted so that the beneficiaries are rightfully attributed to the correct physicians. Also in terms of the improvement activities inventory, back in March, we added COVID-19 clinical trials as a new activity in the inventory and created some qualifications around the type of trial and the requirement that data be recorded through a clinical data repository or clinical data registry to share the results on a much faster track. We are also now expanding the inventory to include a clinician's treatment of a patient diagnosed with COVID-19 outside of a clinical trial. But again, the data must be submitted electronically through the data registry. So again, some minor modifications that's specific to the IFC3. So now moving on to our next, and we're gonna spend more time on this, and you can see this is what the title of the physician fee schedule proposed rule is if you were to go to the Federal Register and look at the 1,300-page document. So we're just gonna call it the 2021 physician fee schedule proposed rule. And we're going to talk about 4 main components. We'll talk about what we are looking to expand in terms of telehealth permanently, and I'll explain the difference between what's going on in the public health emergency currently and what we are allowed or statutorily permitted to permanently extend beyond the public health emergency and the difference between the two. We'll talk very briefly about E&M coding changes that are going to go in effect in 2021. I mentioned some changes to the MIPS program and then also opioid treatment programs. I just want to make sure that everyone is still aware that that is a new service and we're still trying to make sure that awareness levels are increased. So before I talk about the proposed rule, and for those of you who have come to the fall meetings and heard me talk about the proposed rule for many, many years at this point. A couple things that you need to know is that there is a formal process by which you submit your comments in order to be officially considered. You do that through regulations.gov with the mail, by hand or courier if you happen to be in the vicinity of central office in Baltimore. But the main takeaway here is that number one, the deadline to submit comments is October 5th, 2020. Any questions, comments, concerns that are expressed during this presentation, great for my awareness, but if you want to have them officially considered for the final rule, which will probably be published around December 1st this year, you have to formally submit them through the proper channels. And I believe that the link in this, on this slide, will take you directly to the location on the Federal Register website where you submit the comments. If you're having trouble finding the Federal Register, if the link's not working for some reason for you, email me and I will send that to you. So let's talk about telehealth. Now, and we talked about telehealth in some detail back in April, but if you weren't here, just by way of overview, the Social Security Act, Section 1834M, specifies the circumstances on which Medicare could pay for telehealth services. Now, there are certain limitations that are built into that law, or where we get the ability to pay for telehealth services: geographic, site of service, practitioner, and technological restrictions. So in a nutshell, geographic, basically outside of the public health emergency. So let's put aside the fact that we're in public health emergency and we're talking about regular Medicare telehealth. The geographic limitations is that it must originate in a rural area. So an area that is designated as a rural area or non-metropolitan area. The site of service, there are certain sites that are permitted to be the originating sites, usually hospital, other types of care site services. Certain practitioners are permitted outside of the public health emergency to bill and be paid for telehealth services, and also technological restrictions. And this was a big source of debate and conversation early on in the pandemic because of the audio and video component. So geographic, site of service, practitioner, and technological restrictions. In response to the public health emergency, and because Congress, and this is the important part, Congress passed the CARES Act that allowed CMS, gave CMS the authority to waive those restrictions for the duration of the public health emergency. So as you know, we said that telehealth does not have to be limited to rural areas during the public health emergency. The site of service, we are, for example, allowing the home to be the site of service. A physician can provide services from home to their patients. We've expanded the practitioners in terms of who can provide certain services, and this is especially pertinent to physical and occupational therapists and speech language therapists. And then the technological restrictions, of course, we now have telephone-only telehealth services that we are paying for, again, during the duration of the public health emergency. Again, it is important to realize that we're doing that because it was legislatively mandated by Congress. So when we talk about what we are proposing in our proposed rule, we do not have the authority to propose to extend those waivers of the exceptions. So that is going to be a legislative discussion that will take place once the public health emergency is over, whenever that may be. But what is important to realize is that those exceptions, so the geographic site of service, the practitioner, and the technological restrictions, they have been waived and they continue to be waived for as long as the public health emergency is in effect. So now we move to the proposed rule and what we are able to do in terms of adding services to the list of telehealth services that Medicare can pay for on a permanent basis moving forward. And we have the statutory authority through proposed rulemaking, and we do this every year actually at this time, where we propose to add services to the list of services that we paid. So we are proposing the services that are here on slide 10 permanently to the Medicare telehealth list. And as you can see, these include lower level established patient home or domiciliary visits and assessment and care planning for patients with cognitive impairment, group psychotherapy, and 2 add-on codes associated with our previously finalized office E&M visits. We are also proposing this year to create a new category, or category 3 of services, because if you go back and if you read how we add services on an annual basis, there's a category 1 where they are telehealth services that are similar to services that are already on the list. Category 2 are those services that are not similar to those services already on the list. And then we are proposing to add a category 3. And this new category 3 describes services added to the Medicare telehealth list during the public health emergency. So they are currently in existence on a temporary basis that will remain on the list through the calendar year in which the public health emergency ends. So let's say that the public health emergency ends June 1st, 2021. These services we are proposing would stay on through December 31st of 2021. If the public health emergency ends on March 31st, 2022, these services would stay on the list until December 31st, 2022. These include lower level emergency department visits, higher level established patient home visits, and certain psychological testing services and nursing facility discharge day management. And the reason why we would be adding them on until the end of the calendar year is to give us more time to consider whether or not they should be moved into the permanent list. On top of that, we have certain services that we've added added temporarily to the Medicare telehealth list during the public health emergency that we are not proposing to add, but we are seeking comment. So they are going to be on the next 2 slides. You can see some of the therapy services and physical and occupational, some speech language, some psychological, neurophysiological testing. And again, so we are saying our proposal is not to add these on a permanent basis. However, we seek comment, and I anticipate that we are going to get a lot of comments and a lot of dialogues on all of these services, because we've seen that we've gone from about 14,000 telehealth services a week to more than 1.5 million in like a 6-week period. So we've been overwhelmingly met with positive feedback, both by clinicians and by seniors. I think that there was some hesitation on some of our seniors in the beginning of the pandemic because they didn't trust the technology, but I think that overall it's been a positive experience for most Medicare beneficiaries. So a couple of other proposed policies for the communication technology-based services. We're clarifying that certain non-physician practitioners, such as licensed clinical social workers, clinical psychologists, physical and occupational therapists, and speech language pathologists, can furnish the brief online assessment and management, as well as virtual check-ins for check-ins and remote evaluation services. I also want to mention that one of the services that we added temporarily were the telephone-only visits, and those were the overwhelmingly positive and popular 99441 to 443 codes. And these were codes that we adopted and we revalued so that practices that were talking to their patients for longer periods of time than just the e-visit, not the e-visit, but the virtual check-in, was actually getting paid akin to what they would be getting paid for, let's say, a level 2 through 4 in-person visit. So even though we are not proposing to permanently add those onto the list, we are seeking comments specifically as to whether or not CMS should create codes that are similar or analogous to the 99441 to 43. Basically like a virtual check-in, but for a longer period of time. The check-ins are usually 5 to 10 minutes. And also what the payment rates would be. So I think that that's going to be another source of a good number of comments that are going to be generated. So again, 99441 to 443, very popular during the emergency. We are not proposing to permanently add them on, but we are seeking comment as to the creation of new virtual check-ins that would be a longer period of time. We also recently finalized payments for 7 remote physiologic monitoring codes. We're clarifying in our proposed rule that payment policies related to RPM services and described by CPT codes 99453, 454, 99091, 99457, and 99458. And proposing a permanent policy clarification to RPM services that we finalized in the previous interim final rule. So these are things such as measuring weight, blood pressure, pulse oximetry, and respiratory flow rate. We're also clarifying that the medical devices that are provided to the beneficiary in order to do the RPM services are defined by Section 201H of the Federal Food, Drug, and Cosmetic Act, which I did not know about. And it must be, the device must be able to record data that's reliable and valid and sent electronically directly through the EHR system and not self-reported by the patients. In terms of virtual supervision, we adopted an interim final policy in one, and I see my camera is going a little wonky. Let me stop my video and restart it. Okay, good. We adopted an interim final policy revising the definition of direct supervision to include virtual presence of the supervising physician or practitioner using interactive audio, video, real-time communication technology. And what we're doing in the rule is to continue this policy up through the year in which the public health emergency ends, or December 31st, 2021, whichever is later. So if the public health, again, if the emergency ends, let's say June 1st of 2021, then this would stay in effect through December 31st of 2021. And again, if it's in a later year, it would be through the end of that year. We are again seeking specific comments as to whether or not there should be any guardrails in effect as we finalize this policy. So again, direct supervision using real-time audio video communication between the supervising physician and the other practitioner. And also if there are any risks to the beneficiary in extending this policy. We're proposing to make permanent our policy for the duration of the COVID-19 public health emergency that allows non-physician practitioners, including nurse practitioners, clinical nurse specialists, physician assistants, and certified nurse midwives, to supervise diagnostic tests as allowed by state law and scope of practice. Of course, the non-physician practitioners would maintain any required statutory relationships with the supervising or collaborating physicians. And we had in Philadelphia some one-on-one calls with our partners in the wake of the release of the IFC3, and we got specific positive feedback that they are happy that this has come into fruition. We're proposing to make permanent our policy that we adopted for the duration of the public health emergency, that a physical therapist and occupational therapist can have the discretion to delegate the performance of maintenance therapy services as clinically appropriate to therapy assistants. And this was, again, a good source of dialogue in May as we try to expand the types of practitioners who could do certain services either in person or via telehealth. So the therapy assistants were also brought under the umbrella. And we're also broadly clarifying that therapy students and students of other disciplines working under a physician or practitioner who furnishes and bills directly for professional services, that the students may document in the medical record so far as it is reviewed, verified, and signed by the billing physician. Just want to briefly go over some of the things that we touch upon in terms of teaching physicians and residents. Teaching physicians may use audio, video, real-time communications technology to interact with residents through virtual means. And we're proposing that that will meet the legal requirement that teaching physician renders sufficient personal and identifiable physician services to the patient to exercise full personal control over the identifiable or over the management of the portion of the case for which the physician fee schedule payment is sought. Teaching physicians involving residents and providing care at primary care centers, which is usually commonly called the primary care exception, can provide the necessary direction, management, and review for the resident services using audio, video, real-time communications technology. And then in terms of moonlighting, the third bullet for the duration of the emergency, Medicare considers the services of residents that are furnished outside the scope of their approved graduate medical education programs and furnished to inpatient of a hospital in which they are having their training programs can be separately billable to Medicare. Moving on quickly to E&M and analogous visits. Again, last year, we finalized that we will be largely aligning the office E&M visit coding and payment policies with changes that were adopted and laid out by the AMA CP editorial panel. And I have discussed this with you over the last couple of years. If you remember, I think it was in 2018 where CMS had proposed a different structure for the E&M codes. And then based on feedback and work that we did with the AMA CPT editorial board, we revised our proposal. And we finalized last year that we would be implementing that in January of 2021. That is still on track to happen. The policies that we are still on track to implement include redefining the codes to rely on either time of the billing practitioner or medical decision-making for selecting visit level with performance of history and exam as appropriate. We are still going to be deleting the 99201 code, which was the level 1 new patient code. And then all of the details about medical decision-making and time and whatnot should be able to be linked to the AMA website web link that's here on slide 19. And again, once you have an electronic copy of this, it should take you directly to that portion of the AMA website. And if you can't get to it, just reach out to me and I'll make sure that you have access to it. So again, not a whole lot of new stuff here, just a little bit of refinement of what was finalized in 2019 for this year's fee schedule. We're proposing a refinement to clarify the times for which the prolonged visit could be reported, and also proposing to slightly revise the times that are used for the rare setting for this code set. So we talk about 99XXX, which is the add-on, and that's going to be reported when the time is used to select the visit level, and the maximum time for the level 5 visit, so that's the highest level, is exceeded by at least 15 minutes of additional qualifying time. There are also some refinements for each of the bullet points here. I think there are 6 or 7. For sake of time, I'm not going to review them. If you want to know specifically what we are going to be revaluing in terms of time for each of those code sets, again, reach out to me. I'll be happy to share my notes with you. But I want to move on so that we can talk about some changes that we are proposing for the quality payment program. So you may remember that last year we were talking about this new MIPS values pathway, or MVPs, and that was the new BUZZ acronym that was going to be implemented starting with the 2021 performance year. So we are putting that on hold. So the MIPS value pathways will not be starting in 2021, even though we have started some discussions with our external groups about what those MVPs are going to look like, both in terms of the specialties and also with the condition codes. But that is going to be put on hold until 2022. We are going to be introducing on the APM side what we're calling the Advanced or the APM Performance Pathway, an APP. They're going to have fixed measures, and we'll be having more discussion about that later in the year, in the beginning of next year. We're going to be doing, there are some major changes in Medicare Shared Savings Program. We're also sunsetting the MIPS scoring standard, and we'll talk about that in the next slide. But for the new APP, there are going to be a set or a fixed set of measures for each performance category. And this is going to differ from the MIPS, the general MIPS program that individual clinicians and groups who are not part of an APM or not part of the Medicare Shared Savings Program will be participating in, and we'll talk about that. So for the quality category, there's going to be 6 measures that are preset for all MIPS APM participants. For those in the Shared Savings Program, they'll be required under the terms of the Shared Savings Program to report those quality measures via the new APP. Cost performance is going to be reweighted to 0 because participants are already averaged to the cost of their APM. Improvement activities, they're still going to be valued or weighted at 20%, but by virtue of the fact that you're participating in APM, you're going to get 100% of that participation or improvement activities automatically. And the promoting interoperability will be 30% and reported and scored at the individual group level, which is required under the Shared Savings Program. So the APM scoring standard is going to be sunset, but though we won't be scoring APM MIPS under the APM scoring standard, we will allow the APM at least to report to any part of MIPS, whether it's through the APP or otherwise, and APM participants may report with their model entity, or they may report to MIPS as an individual or group, however they choose to do so. So moving out of the new APP and into the general MIPS performance categories, again, for performance year 2021, we are proposing, I mentioned earlier, to sunset the web interface as a quality reporting option. And this was an option that was available to groups of 25 or more eligible clinicians, so long as they were reporting all, I think at one point it was up to 18 measures that were part of the web interface. So even though that is going away as an option reporting, there will still be other options that ACOs, Medicare Shared Savings Programs, virtual groups, or other groups will be able to report. They would also be able to select their own quality measures instead of reporting a predetermined set of measures. So again, there were certain measures, all of which had to be reported in order for the web interface to be used appropriately. We're proposing to use the performance period in 2021 and not historical benchmarks in order to score quality measures for the upcoming 2021 year. And this is the first time that we're doing this. And we're doing this because we're concerned that because of the public health emergency and with any issues that may have come up with reporting 2019 data at the beginning of this year, because the reporting deadline for 2019 was right when the pandemic started, we decided that we're going to be using data in the performance period instead of historical benchmarks. In terms of cost, really no updates other than the percentage weight is going up by 5%. We're also going to be including telehealth services. So I mentioned in terms of beneficiary attribution that we're going to be including telehealth services in those codes. We're also going to be including those for cost in order to give a more accurate representation. We still have the 18 measures, which are the 18 episode-based measures, and then also the total per capita cost and Medicare spending per beneficiary. For improvement activities, only a few updates here. We've made a couple of updates to the inventory to modify some of our existing improvement activities. And we've also made some proposals regarding the method that new improvement activities can come to us. So we had a specific way that we introduced activities in the inventory. We're making some revisions on how we can more quickly add those inventories as the situation arises, such as with the public health emergency. And I mentioned some of the specific COVID-related improvement activities that we've included in the inventory, both through the IFC and that we're proposing to add at least through the emergency beyond the emergency itself. Then for promoting interoperability, again, this is the EHR portion of the program. Minor updates, we're retaining the query of the PDMP as an optional measure. Now you can get up to 10 points if you report on that. And we're changing the name of the supporting electronic referral loops by receiving and incorporating health information. It's a mouthful. We're replacing the word incorporating with the word reconciling. And then we're also adding a new health information exchange bidirectional exchange measure, which would be worth 40 points. And that could take the place of the two existing measures that involve a health information exchange. So you'll have the choice between either using the new bidirectional measure or by reporting the two existing measures that relate to health information exchange. Proposed weights, as you can see, and we talked about this before, you probably heard me talk about that we were going to be slowly increasing the percentage that cost would be given for the overall performance score. So we've increased it by 5%, which is basically the rate we've been increasing it over the last couple of years. So we're proposing in 2021 that cost would be 20%, and we take that 5% from quality. So for those, and this is outside of the APP category rates that we talked about earlier. So it's 40% for quality, 20% for cost, 15% for improvement activities, and 25% for promoting interoperability. One small change here about the performance threshold. Last year, we had finalized that the performance threshold for 2021 would be 60 points. We are backtracking and we are proposing to lower the performance threshold for 2021 down to 50 points. The exceptional performance bonus will remain at 85 points. Exceptional performance bonus, again, is the extra money that's set aside for those clinicians and practices that score above 85 points, both this year and next year, to get an additional increase in their payment adjustment. And again, just a reminder, whenever we talk about payment adjustments, that it is subject to budget neutrality. And I think that we all know what that means at this point. Specifically, what we're doing in relation to COVID-19 for 2021, we talked about the new improvement activities. We're proposing to double the number of bonus points that would be available under the complex patient bonus. So you may not know that you can get bonus points if you have complex patients, and there's a way that we derive which patients are determined to be complex. We've incorporated COVID into that definition. We are increasing next year, proposing to increase that bonus from 5 points to 10 points. We're also making a proposal that will allow APM entities, so if you're in a model, to submit a reweighting application based on extreme and uncontrollable circumstances for the 2020 year. And then also for our third-party intermediaries, we touched on this last year, but we're also making proposals that require our qualified clinical data registries, the QCDRs, that they should be able to support the new MVPs and MIPS value pathways starting in 2022 and the new APPs next year in 2021. So I want to move it over to the OTP benefit. Again, this is an opioid treatment programs. And again, I don't know that this is going to specifically impact you folks, but whenever I'm in front of a clinician or a practice administrator audience, I want to at least get the awareness out there that this is a new benefit. And this was from the Support Act that was passed in 2018. And it basically established a new benefit under Medicare Part B. And I think, unfortunately, that the level of awareness about this new benefit is not quite where we need it to be. So again, even though this may not directly impact you, again, we want to make sure that you have this awareness that it is a new benefit. Under the OTP benefit, as you can see here on slide 28, it covers a whole host of services under Part B, many of which are bundled. We've talked about the bundled services in the past. Specifically, what we are proposing is to add naloxone to the definition of OUD treatment services. And again, naloxone, as you probably know, is the opioid reversal agent that you take when somebody is suffering a possible overdose. And we're also changing the definition of OUD. So we said we were specifically targeting opioid use disorders, and we are expanding that for all substance use disorders. So that's really the main part of what we're proposing for 2021. The other stuff on here, excuse me, talks about some of the pricing and the of the actual drugs themselves. And again, probably not pertinent to this audience, but again, I want to make sure that you're at least aware of what we are proposing in terms of the OTP benefit. And again, here I said we're making it inclusive of all substance use disorders, not just OUDs. I also would be very interested in any feedback that you might be hearing from anybody in your communities, anyone in your practices that have had any interactions or doing anything with the OTP benefits, whether or not you think that there is just not an awareness that this is a new benefit, or if there has been an issue, and this is what we've heard too, about enrollment. So OTPs, as they are a new benefit being paid under Part B, it's also a new provider or supplier type. So there is a process by which a treatment program does have to enroll in the program, even if they were in the Medicare program as another type of provider of service, another service provider type. There is a specific OTP enrollment process. So I'm always trying to do environmental scanning. So anything that you have regarding the OTP benefit would be really great for us to know. We also are going to be proposing the requirement of e-prescribing of controlled substances. It is allowed now in all 50 states and the District of Columbia, and more than a dozen states actually require that there are electronic prescribing measures put into place. We are going to be implementing 3 phases for Medicare under Part D. The first stage, which we are actually in now, is a request for information. And that's basically any exceptions to any requirements that Medicare would put into place as it relates to the electronic prescribing of controlled substances. And also whether or not there should be an imposition of any penalties or fines for non-compliance. So it is a general RFI, request for information. The second phase, and by the way, that went on display on July 31st. Those comments are due, as you can see here on the slide, by October 5th. The second phase is after we collect that information through the RFI, is that we would implement the standard that would be effective January 1st, 2022. So not this upcoming year, but in 2022. This is the proposal. It would be in the physician fee schedule rule. So this time next year, we would most likely be talking about what we would be proposing in terms of a new electronic requirement for prescription of controlled substances. And then the third phase would be to finalize the exceptions and the penalties that we are requesting information for with this RFI. So right now we are looking for exceptions and what the penalties or fines should be, if there should be any. This time next year, we will be talking about what we are proposing in terms of implementing it for 2022. And then phase 3 would be the enactment of that. So again, the feedback should be linked on this slide. If you can't get to the link for whatever reason, please send me an email. I want to quickly just finish up by talking about seasonal flu and what we are doing in terms of outreach And what I've done here is I've gathered some data that my colleague Debbie Fearman, who I believe is on this call, shared with me. As you can imagine, that this year's flu vaccine outreach effort is going to be of utmost importance. What I've decided to do is just to put some numbers together, and this is probably not going to be news to anybody, but the takeaway here is to really impress upon you the importance of getting the word out to your patients. And I think that you as clinicians, as practice managers, as those that have a direct line to our beneficiary communities, and you can really have an impactful message by talking about why the flu vaccine is so important, especially this year. And again, you probably have seen this information. This is from the CDC. Flu cases cause about 140,000 to 810,000 hospitalizations each year, and between 12,000 and 61,000 deaths in the United States. And that number, I think, is going to resonate, especially as we're talking about hospitalizations and deaths that are related to COVID. And hopefully will impress upon your patients the importance of getting the vaccine. For adults, and again, I don't think this is news to anybody, unvaccinated patients who are 18 or older are hospitalized with the flu 2 to 5 times more likely to die than those who were vaccinated. Vaccinated individuals aged 18 to 48 and also 65 or more who are hospitalized with the flu are 37% less likely to be admitted to the ICU. And then you also see some of the data we have as it relates to children. The disparities, probably again, not a surprise here. So we think, you talk about reasons, why do people not want to get a flu shot? They think that it's not effective. They think that it's going to cause them to actually get the flu. They think that it's not safe, or because of the cost of the vaccine. And as you can see in all of those factors, non-English speaking respondents tend to have higher rates of not getting the vaccine. So again, another data points that we are taking into consideration for this year's flu campaign. We're also going to be using Medicare data. So we have some data that's basically or specifically from Medicare Part B claims, and then also from the Medicare Current Beneficiary Survey. This is back of 2017. So based on which data source, between 54 and 70% of Medicare beneficiaries actually receive the vaccination. So if we're looking strictly at Part B claims, it's 54%, and that is only fee-for-service claims, so that's traditional Medicare. But we're also looking at Medicare Advantage patients when we're looking at the beneficiary surveys, and that could be upwards of 70%. So what we know about Medicare beneficiaries, those that are 65 to 75 have about a 10 to 15% lower rate. African American and Hispanic populations also have lower rates. People with less than a college education have lower vaccination rates. Dual eligibles have lower rates. Men have a 3 to 5 lower vaccination rate. Rural tend to have lower rates in claims. And then those who have higher incomes have better rates than lower incomes. And again, this is probably not a surprise to everybody, but again, data that we like to have in our back pocket when we are out there promoting this year's campaign. So with the COVID-19 public health emergency, we are coordinating our outreach efforts with other key HHS operating divisions such as the CDC, and we're going to be officially kicking off our outreach efforts pretty much within the next couple of weeks, so by the end of September, and we're really going to be ramping it up during Medicare open enrollment period, which runs from October 15th through December 7th. And again, what you want to do is to share this information with your patients. The CDC recommends you get your vaccine between late September and early October so that you're covered for a longer period of time. If you get it too early, you may not be getting coverage for later in the season. So you're going to be seeing a lot more messaging. And again, we'll be working with our partners such as the Pennsylvania Medical Society in getting this information out, not only to your patients, but again, also to your physician's offices, because again, we really think that you folks have the best direct line to the patients and probably have also the greatest level of confidence with your patients as well. And again, these are pretty, I think for us, obvious reasons of why you get the vaccine. And just as a reminder, Medicare and Medicaid both cover the vaccine. The Part B deductible on the Medicare side does not apply to the service. So Medicare covers the shot as long as you are eligible for and enrolled in Original Medicare, and Medicare Advantage also covers the seasonal flu shot. And Medicaid as well covers the flu vaccine for children and adults. And we're going to be working with the Insure Kids Now campaign to make sure that those children under Medicare are also covered. So a lot of stuff to share. This is, again, the most important slide I always say at the end of my presentations, because this is how you get in touch with me. Once I sign off and all of your questions pop in your head, please do not hesitate to reach out. My job, again, is provider and clinician outreach and education. My job is to respond to your questions, comments, concerns, policy clarifications. I don't always have the answers for you right away, but I do my best to try to get them to you as quickly and efficiently as possible. So with that, I will ask Jennifer to see if there are any questions that I can try to answer.
Thank you so much, Patrick. We did have a few questions come in, and Deanna will read through them shortly. But if you do have a question for Patrick, now's the time to ask. Go ahead and type that into the Q&A icon down at the bottom of your screen. And, you know, Patrick, I think it's wonderful that you put your contact information out here to everybody. You know, we appreciate how accessible you are, not just to the PAMED staff, but to all of our members and attendees of these meetings. So thank you for that. And now I'm going to ask Deanna to go through our question.
Thank you, Jennifer. Great presentation, Patrick. We appreciate your time with us this morning. I do have some questions for you. The first question I have was presented from Liz Rio. Patrick, can you please confirm that MIPS is still just for practices that accept Medicare and not available to Medicaid practices, especially pediatricians?
Yes, so MIPS is still a Medicare program, Medicare fee-for-service program, traditional Medicare, so it does not apply to Medicaid. When before MIPS, you may remember meaningful use, and I've been around long enough where I've talked to you folks about meaningful use for a number of years. There was a Medicaid component to meaningful use, but the MIPS program is strictly for Medicare.
Thank you. Sean Shalady has asking, will you be offering training specific to the new E&M codes?
So we will, over the next couple of months and probably into the new year, I would think that CMS Central Office, we have staff in Baltimore and Washington who do national training calls. I don't know of specific E&M training that is going to be offered. I do know, and I haven't yet gone to actually research it, that I think that the AMA has training webinars or videos on their website. I would have to go back and see if they're actually there. I also would reach out to Novitas, because I know that they still have an education and outreach component as well. Whenever we have specific coding and billing questions, that's usually under the purview of a Novitas or Palmetto if you're in the southern part of our region. So we can definitely look in to see what is being offered either by the MAC or by the AMA in terms of specific coding training. Usually when we talk about the policy part of it, such as we did today, we usually talk about what the policy was proposed, what was finalized. We'll get into some coding in terms of, I mentioned about how you would bill for certain increments of time, or if you're going to use MDM. But when you get down to the actual how do you bill, how do you code, that's usually under the purview of the MAC. But I can follow up to see if Novitas has anything planned for that, either at the end of this calendar year or at the beginning of next year.
Sounds great. Thank you. We have a few more questions for you, Patrick. Steve Hamill would like to know, will AUC member physician groups be reporting full MIPS measures outside our ACO for the 2021 reporting year?
I'm actually reading, well, ACO member physician groups will be reporting full MIPS measures outside of our, Stephen, I don't believe so. So I think that as part of the ACO, and I would have to follow up because admittedly, the ACO policies, you know, they're changing, and I would have to go back to those folks to clarify, but I believe that the ACO itself are reporting on behalf of the group. But I will definitely follow up with that, because I think that I don't want to misspeak, because I think the policy is changing, but I believe that the entity is reporting on behalf of the group. But let me follow up on that. And Deanna, would you be able to, it just disappeared, make sure that I have copies of these questions?
Yes, they may not be on the screen, but they have not disappeared. They're just archived right now.
Okay, yeah.
So you can make room for
make sure that when we're done that I have these questions.
Thank you, Patrick. We'll make sure that you get them.
Okay.
We have a similar question from both Christine and a Robert. And we will be presenting a slide on this new AMA CPT code 99072.
Yeah.
Is there anything that you can offer regarding this code? We know it's brand new.
Yeah, I have not heard anything about that specific code, and we did not in the proposed rule, there's nothing. I don't see 99072, and in the latest IFC, I'm just looking at the code quickly.
And Patrick, not to interfere, but I do want to let you know this just came out at the beginning of the month, and we
I don't have anything on that as yet.
Okay, so everyone, we will be presenting a little bit more information on this brand new code during our practice support presentation. We had one more question come in. Diane Detman would like to know, under the 2021 physician fee schedule proposed rule section slide, you have listed amend the frequency limitations of subsequent nursing facility visits. Can you further explain that?
I believe, let me see if I'm reading, let me go back. That I believe, and again, I'll have to go back because I think that this was an offset of some of the telehealth, the limitations on how many non-in-person visits were allowed. And I think, and again, I don't have a direct answer, but I think that this, if I remember it correctly, had to do with in-person visits versus visits that were being done over telehealth. But I would have to clarify that. So let me go back, and Deanna, I will send you an update on that, and you can share that with the group.
Thank you very much, Patrick.